Thank you, Harold, and thank you, everyone, for the opportunity to speak. I'm the president and CEO of ICSI, commonly called the Institute for Clinical Systems Improvement, and I want to talk to you about integrating mental health into primary care. ICSI has been around for 20 years. We are a collaboration of the multi-stakeholders that you've heard before. We're supported by nonprofit health plans that many were involved in the multi-payer initiative that you'll hear talked about later, as well as member dues and sweat equity. We have 300 physicians who alone work on our guidelines, which are the foundation for our collaborative and the strong evidence-based process. And those guidelines are out there free of charge and have been for 20 years. But this is one of the challenges for a collaborative like us, is we've been providing this free of charge for 20 years for the nation and the world, and it's not a sustainable business model. So help me here. So anyway, before we go on into talking about integrating mental health, I want to see a show of hands for how many of you either know someone with depression, with risky substance abuse, or a serious mental illness. Let me see a show of hands. Okay. So that's just a quick prevalence check just for in this room here. I want to tell you about my friend, and I'll call her Susie. She lives in one of those states that was clear on Harold's chart that doesn't have an NRHI member there, that doesn't have a collaborative. Her family and I knew for months that she needed to see someone for depression. And we finally got her in to be seen, and she did get started on some treatment. But Susie, as I call her, I called her up several weeks later and said, "How are you doing?" She was not getting better. No one had contacted her. She had no follow-up. I said, "Well, did you get some assessment to know where you started or how, you know?" And I mentioned like this PHQ-9. She said, "No, I haven't heard anything about that or whatever." So some of what drives and should drive all of us is that mental health issues are huge in our society. And primary care and the healthcare system, as this slide represents, is not doing a good job, and we can do better. And there's lots of evidence. So enter in Diamond. We had a depression guideline for years. But what we saw, and based on research, was that there was a model that could achieve better results, but there was no one having that kind of model. We'd never been trained on that model as doctors and nurses and social workers and clinics, and there was no reimbursement. There was no sustainable business model to help us actually accomplish that. So we actually started, based on that research trial, Depression Improvement Across Minnesota, offering a new direction. I described to you what the current model of primary care looks like for Susie. However, there is a different way, but it required us in Diamond to redesign care and to redesign payment in order to get to a different outcome. So what's the redesign of care that needed to occur? It's a collaborative care management approach in which you had care coordinators, primary care providers, and a consulting psychiatrist working together to achieve better outcomes for depression. They did panel management, population management, using guidelines, having a registry, which could actually be a way to document as also to be able to do care management, to know when someone like Susie had fallen through the cracks and had not been contacted, had not come back to a visit, to know whether a person was actually improving or not improving on their PHQ-9 scores, which is a true patient-reported outcome, and getting to the gentleman's question about are we getting towards real outcomes. And I can tell you in Minnesota that initially, as we were working through our depression guideline and over the years, that we were measuring refills on antidepressants. And through our quality improvement work, what we found is we go into clinics and they were working really hard on documenting the refills of the antidepressants so they'd score better on the measure that, was out there. And it actually was a HEDIS measure at that point. And we said, well, do you know if the patient is taking the medication? Do you know if the patient is getting better or they're just getting the refills? And it was like, oh, yeah, we got the wrong measure. But through our quality improvement work, and then through our sister organization of Minnesota Community Measurement, we worked really hard to get acceptance of PHQ-9 as a patient-reported outcome measure with clinicians who found they could use it, they could do it, and they could see remarkable results. And then to get it accepted, to be publicly reported, and thanks to Minnesota Community Measurement, we took it all the way up to NQF, and now it's a nationally endorsed measure at NQF. Then to actually say, how do you work with doctors and patients to think about care plans and what does that look like in a real clinic situation and for the patients? And then how do you do this intensification of treatment? You heard about the clinical inertia. It is so prevalent. People think, well, let's just wait till next time to change your medication, or let's just see if things get better. To really say, let's intensify treatment. If the PHQ-9 is not getting better, if that outcome's not getting better, let's change what's happening. Let's get over that clinical inertia. But that takes a team effort. And that's where the psychiatrist is particularly important here in this redesign of care. We were able to find that 2 hours a week of a psychiatrist's time into this team of the care coordinator and the primary care clinicians, 2 hours a week of a psychiatrist's time could manage 100 to 200 people with depression. Now that's a value proposition for how to use that scarce resource of a psychiatrist in a community to manage a very common problem like depression. Now, what's the business model for this? And there wasn't a business model for how to do that until we did the redesign of payment. So essentially, the nonprofit health plans came together and said, looked at what we were producing and said, let's do a redesign of payment to sustain that. And so it's really a bundled care coordination payment for primary care and psychiatric care. And the nonprofit health plans have been participating, and the medical groups actually decide how they're going to divide that reimbursement. So we're not prescriptive about that. Some medical groups already have a psychiatrist on staff, and they're more of a staff model, so there's not some fee-for-service kind of approach with that. Others actually hired a psychiatrist, and we gave them a range that a psychiatrist in our community was $200 to $300 an hour, so just to give them some range of what they might expect to be paying with that. So people did it in many different ways. It did take in this kind of changing model, a lot of interactions with psychologists and psychiatrists in our community to understand we weren't trying to take business away from them. We were trying to actually free up their time to take care of the people that primary care could not take care of, and to actually free up the resources. I think we calculated one time we only had 125 psychiatrists in the whole state of Minnesota. We needed to use that valuable resource wisely. And once we kind of worked through all that relationship issue, they really understood and have been big supporters of us in this process and leading some of that effort. So redesign of care and redesign of payment was what it took to actually get this new model for depression care into the system. And the results are, drum roll, that there's actually better results than usual care in response rates and remission. And I can tell you for every decrease in that PHQ-9, we've been able to show increases in productivity. And so that's very important to employers. And then if you just think about being a productive mom or dad in your own homes, that's another level of productivity that we could really speak about. So outcome measures getting better experience of care for patients and providers. And then looking at economic studies, what do we know so far? We're still working on calculating that for Diamond, but we know from the original research that was done that there's an investment up front. It's a study done in Medicare patients, but long-term, there are net cost savings for this investment in this collaborative care model for depression. So let's look at some other places where there are economic cost of behavioral conditions. So if you look on the far right, you see depression does have economic costs for healthcare and productivity. Tobacco use, Jim alluded to earlier that we're thinking about that and working on that in Minnesota. I've been seeing our prevalence of tobacco slowly decreasing, so we're really proud of those efforts. But what about this middle section here? What about substance use? What about excessive drinking and drug use? And unfortunately, in Minnesota, we are in the top 5 in the nation for binge drinking. We have a severe problem with binge drinking. I take some mild consolation that Wisconsin has more than us. But I really should not take much consolation with that, because Chris Querum is in the room, so from Wisconsin. Nevertheless, enter Diamond and SBIRT. So to integrate, to think about how we could do substance abuse screening. So we're really missing opportunities to intervene with risky substance users and to really do it early, to do it with the mild and moderate people who are abusing substances and before it becomes addiction, before it becomes severe. So with that, we have combined a number of NRHI efforts into something that we're calling Partners in Integrated Care. So we're combining what's happening in Minnesota, what's happening in Wisconsin, they are addressing it, and what's happening in Pennsylvania. So to combine those efforts and applied with Pennsylvania and Pittsburgh Regional Health Initiative as the lead for an ARC grant for Partners in Integrated Care, in which we are bringing these two things together, the depression and substance abuse screening and treatment and interventions, building on this collaborative care management model. So we are very thankful that ARC has been supporting this, and we're in the process of implementing that as we speak. And in the grant are planning to disseminate beginning through ICSI, through NRHI, which is a great model in thinking about how we can take these care models and being able to get them across the country. And my friend Susie will have one in her state, hopefully, in the future. So let's enter in now to another place. How do we focus these efforts? How do we directionally put them into the places and people with highest risk and highest need? And so enter COMPASS. So it's the care of mental, physical, and substance use syndromes in people with chronic disease. So ICSI and 9 other partners were very fortunate to receive from CMMI one of the Healthcare Innovation Awards. It's $18 million over 3 years in 7 states. And it's really about treating depression in patients with diabetes or heart disease with the option for substance abuse screening. We framed it as a triple aim bullseye in being able to achieve better mental care and medical care for people across our country. The consortium of partners, as you can see, is a mixture of NRHI members and some other partners, and we have 2 supporting partners of Health Partners Institute for Research and Evaluation and the AIMS Center that did some of the original research on depression and the collaborative care model. So we have a broad geographic reach. It's an opportunity to test this collaborative care model across a variety of health systems, many different, all the way from just independent practice physicians to some staff model, group model practices. And part of what we are to do is to create payment models that we will submit to CMS based on the results of our initiative. So in summary, I think there are some great ways that we can integrate mental health and the care for mental health conditions into primary care. They're proven models, and NRHI partners are implementing those models to really improve health, improve the experience of care and quality, and to decrease costs. So thank you very much.